The elbow consists of the humeroulnar, radiohumeral, and proximo-radioulnar joints. Primarily the humeroulnar, and to an extent the radiohumeral joints, form a synovial hinge joint. These form articulations between the trochlea and capitulum of the distal humerus and the trochlear notch of the ulnar and radial head. The joint is supported by lateral and medial ligaments. The proximo-radioulnar joint is a pivot joint formed between the radial head and the radial notch of the ulna. It is supported by the annular ligament. The elbow derives muscular support from the biceps, triceps, brachialis, brachioradialis, pronator teres, supinator, and anconeus muscles. Medially and laterally, it forms common points of attachment for the flexor and extensor muscles of the wrist. It is innervated by the radial, musculocutaneous, median, and ulnar nerves. Let us begin the examination of the elbow with a general inspection of the bony and soft tissue contours. Note any congenital or developmental variations like cubitus valgus or varus. The normal carrying angle for males is about 5 degrees and for females 10 to 15 degrees. Note any nodules like tophi or swelling from the olecranon bursae. In addition, consider the guidelines on observation we mentioned in the beginning. Then continue with palpation. In particular, feel for clinically significant structures like the medial and lateral epicondyles, the radial head, the olecranon, the medial and lateral ligaments, and the ulnar nerve. You may also feel the median nerve, the brachial artery, the bursae, the flexor and extensor tendon insertions, the extensor and flexor muscle groups, and what about here? The biceps and triceps muscles. If appropriate, palpate the epitrochlear and axillary lymph nodes. The active movements can be performed in the standing or sitting position. Ask the patient to perform flexion, extension, supination, and pronation of the forearm. Note the range of movement achieved and the ease by which these movements were performed. That's it, and then rotate all the way up. For passive movements of the elbow, the patient may be seated or supine. Palpate over the posterior aspect of the elbow joint, and with the other hand, guide the forearm to move the elbow through flexion, extension, and hyperextension. Then perform pronation and supination to assess the radioulnar pivot joint. Place the elbow at 90 degrees of flexion and using the patient's forearm, pronate and supinate. The free hand palpates the proximo-radioulnar joint and the radial head. For active resisted movements, hold the patient's arm flexed at the elbow with the forearm supinated. Test for flexion, extension, pronation, and supination. Note the muscle strength, joint stability, the presence of pain or crepitations, and compare with the opposite side. That's fine. Now the other one. If you need to assess some common functional movements, you may wish to ask the patient to pick up an object push or pull on a fixed handle, open a door or the lid of a jar. In the elbow, repetitive tasks such as typing may be a significant factor in the generation of the patient's symptoms.